Welcome everybody to our International Sarcoma Tumor Board. I'm going to be giving a brief overview of sarcoma, the state of the art, and then we're going to go through some tumor board cases and open it to question and answer. So I'd just like to start by introducing sarcomas. Sarcoma is actually the first cancer ever described. Recently, a summer and a half ago, an archaeological dig in Egypt found a bone with clear evidence of osteosarcoma shown on this slide. Sarcomas take a number of different varieties. If you go to the pathology textbook, there's over 200 different types of sarcoma. These on this slide are the 50 basic sarcomas that we see with fairly regular occurrences in clinic. These are the most common sarcomas. Now, each of these types of sarcomas are a different type of cancer. For instance, angiosarcoma is as different from liposarcoma as breast cancer is from colon cancer. So these are completely different diseases, different biology, different treatment. And you'll see some evidence that these are very rare diseases. In the United States, there may be only, can that move? Oh, I got it. There may only be about 12,000 soft tissue sarcomas and about 3,000 bone tumors per year in the entire United States, fairly evenly distributed between men and women. These sarcomas are very different also in terms of their distribution. So sarcomas are different than the anatomic types of cancer like breast cancer, colon cancer, because sarcomas can occur essentially throughout the body. So the most common location is the upper extremity, lower extremity. Second most common locations are the abdomen, followed by pelvis, head and neck, and other sites. Sarcomas are also different in their anatomic metastatic pattern. So when you see a patient with sarcoma, your staging workup to determine whether or not metastatic sites are present really depends on the type of sarcoma. And this really is a fundamental aspect of sarcoma is making the correct diagnosis with an expert pathologist. So for instance, most sarcomas metastasize to lung. However, there are sarcomas such as GIST, desmoid tumor, DFSP that rarely metastasize to lung. If I see a GI stromal tumor or GIST patient with a lung metastasis, a lung lesion, I generally do a biopsy to confirm it because it's often a different type of cancer or maybe even not cancer, such as sarcoidosis or other phenomena. A liver is common for GIST, leiomyosarcoma, angiosarcoma. Myxoid liposarcoma is unusual in its ability to metastasize to fatty areas such as intra-abdominal, pericardial, fat pad, but also to spread to bone. Lymph nodes are very rare. Surgery for sarcomas generally do not involve lymph node dissections like the carcinomas do. Sarcomas are also molecularly driven. So most sarcomas have a distinct molecular event that might be driving that sarcoma, as listed here. The typical workup for a patient is after presentation to the emergency room or primary care physician is to get some type of anatomic imaging, such as MRI or CT. This leads to a biopsy, recommended a core needle biopsy, which leads to staging and diagnosis. The pathology is critical, so all that we do in managing a sarcoma patient rests on the foundation of the correct diagnosis. Our pathologist here at Sylvester Comprehensive Cancer Center, Andrew Rosenberg, is one of the world's best sarcoma pathologists, so we generally have him review all of the new cases that we see each year, and we see about 650 new sarcoma patients per year. And the reason that a sarcoma pathologist should review these complicated and rare cases is that there's a major discrepancy about 20% of the time in the diagnosis that by a sarcoma pathologist that would lead to a change in diagnosis or treatment. Sarcoma treatment with systemic therapy is also driven by the type of sarcoma. There are certain sarcomas, such as clear cell sarcoma, that are resistant to all chemotherapies. Many of the sarcomas are very sensitive. And the goal of chemotherapy is in the patient with metastatic disease is really to treat and shrink and control metastatic disease. However, in patients with a primary sarcoma, we might use chemotherapy in the adjuvant setting to eradicate microscopic tumor cells, to improve on local control rates, to downstage a tumor such that limb or organ-sparing surgery could be possible, but also to understand whether or not an individual patient's tumor is sensitive to that chemotherapy. These are the list of the chemotherapies that we use frequently in that long list of different sarcoma types. So at a sarcoma center, part of our job is to understand the type of sarcoma such that we can determine which of these chemotherapies is most likely to help a patient. Standard chemotherapy for a pleomorphic or a fibrosarcoma, a myxofibrosarcoma, or what has historically been called an MFH or a leiomyosarcoma, dedifferentiated liposarcoma, these common types of sarcomas, the general backbone of chemotherapy is the same as it has been for the last 20 years, the combination of doxorubicin and ifosfamide. Doxorubicin is given, for the optimal response rates, doxorubicin is given at 75 to 90 milligrams per meter squared, plus ifosfamide 10 grams per meter squared. This provides the highest response rates. And so the doxorubicin ifosfamide combination in this study was proven to be superior to single agent doxorubicin in terms of progression-free survival rates, in terms of response rates, and was also found to be superior in overall survival, although that was not statistically significant. Second-line chemotherapy is generally gemcitabine plus docetaxel for most of the sarcoma subtypes. There are a few caveats to this as well. We don't use doxorubicin, we don't use gemcitabine, docetaxel in myxoid liposarcoma nor in synovial sarcoma because it's really not an effective regimen. There are other agents that we would use in second line. But response rates are in the 20% range, partial response rates and stable disease add another 54%. So really about 75% of patients have control of their disease with gemcitabine, docetaxel, and second-line therapy. Temozolomide is a third-line therapy in many sarcoma. It's similar to dacarbazine. They're interchangeable. Dacarbazine is great. It's given once a month or once every 3 weeks. Temozolomide is an oral agent, so it can be titrated on a daily or weekly basis. But both are active, particularly in leiomyosarcomas. There are some newer agents that have been recently approved for sarcoma. The Paulette study led to approval of pazopanib or Votrient with a 4.6-month median progression-free survival, which was superior to placebo, as you can see on this table, in a variety of different subgroups. Trabectedin was studied in comparison to dacarbazine, and these are patients that were previously treated with an anthracycline. In this study, trabectedin was superior to dacarbazine at 1.5 milligram per meter squared given over 24 hours with a favorable progression-free survival advantage over dacarbazine. So this has been approved for liposarcoma and leiomyosarcomas and is an active option. A newer agent, eribulin, that you might commonly use for breast cancer, has also been recently approved for sarcoma based on an overall survival advantage over dacarbazine in this phase 3 study, 13.5 months versus 11.5 months median survival. This is for liposarcoma only. A newer agent, olaratumab or Lartruvo, has been looked at in combination with doxorubicin versus doxorubicin alone. and this led to an overall survival advantage of nearly a year when patients were treated with a combination of doxorubicin plus olaratumab compared to doxorubicin alone. The issue is we're not sure whether doxorubicin plus olaratumab is any better or not than doxorubicin plus ifosfamide. So studies to try to understand the role of olaratumab, such as combining it with doxorubicin plus ifosfamide, are ongoing. And this table summarizes different studies, so you can't really compare these as a randomized. This is not a randomized study comparing doxorubicin ifosfamide versus doxorubicin olera, but in these separate studies, you get the flavor that the response rates are fairly similar, possibly favoring doxo-ifosfamide. PFS may favor doxo-ifosfamide. However, there wasn't the overall survival advantage was seen with doxorubicin olera in the phase 1/2 study. Whether or not this carries through in the phase 3 study is yet to be determined. So I just like to move on. I'd like to thank you for your attention. This is the sarcoma team at Sylvester Comprehensive Cancer Center. It's a great team that we have to work here. We're happy to work with you in terms of online consultations, virtual consultations, or any services that we can offer in helping sarcoma patients, throughout the world. And so that's all I had to say in terms of a brief whirlwind overview of sarcoma patient management, particularly metastatic. There are roles for adjuvant therapy, but I don't think any of our cases involved adjuvant therapy, so I did not get into that discussion. But thank you for your attention.
Thank you very much, Dr. Trent. We are going to have you stand by for our presentation from the Dominican Republic, coming to you live. So if you hold for 1 second, we're just going to get the slides up. And give over the mouse control. You should be able to control the mouse now, and I'm going to unmute your microphone. Okay, over in the Dominican Republic, can you hear us?
Yes.
And I can hear you. And you control those slides? Can you click the mouse and take control?
Yeah.
Then the floor is yours. Go ahead and have a great presentation. By the way, sorry, as a reminder to the attendees, if you have any questions for any of our presenters today, you can enter them in the chat box in the GoToWebinar control panel window. You can enter questions in English, Spanish, or Portuguese, and we'll make sure they get to the presenters at the end of the presentation in just a few moments. But for now, we turn the floor to our panelists from the Dominican Republic. Take it away.
Okay, thank you. Okay, this is some femme, 30 years old, natural and resident in Pimentel. Now in the hospital since September 19, 2017, with diagnosis of low-grade chondrosarcoma in pelvic, right sacrum region. Patients referred that this clinical picture started 1 year ago after having a sleeping and listening to crash in the process. 7 months later, she presents on a mass of the progressive growth in the upper of the tail, especially of the needle interior that communicates with the vulva deformity. So she decided to go at the hospital when an biopsy is reported to discard syndrome metaplasm and crystoma of possible low-grade, well-different chondrosarcoma. Pelvic magnetic resonance was performed, report expansive image occupant and the projection from the round posterior region of the pelvis measured 60.1 by 8.3 cm in length with the which in the heterogeneous of second captured by the medium contrast and containing the made in the anterior contour of the anterior medial portion of the left right. Tumor appear to original of the nerve root. Pelvic organs are shown to be sliding wide in the anterior position. Immunotherapy is performed, immunohistochemic is report low-grade chondrosarcoma. Patient is sent to us where previous clinical study and featured epsilon is decided to present the patient in the medical meeting to assess the behavior to be followed. There it is, the immunohistochemic. This you want to press, and this is done on the president or after the pelvis. You run with the long, one big as on the mouth in this area. Okay. This is the report I wanted to do. This is on the pelvis. These are the biggest, the mass. It is the same. This is a meter, 60.1 for 8.3. This is the laminate. You can see this, the cell is more big than normal, have the node cell is bigger, is the same of the normal cell. This is the same on this area as the cell for this. This is the report of the biopsy. It reports on malignant epithelial neoplasia constituted by started shell cell. Because of the eosinoph is on the cytoplasm, and we have the focal hyalin. This patient is presented in another committee, but they decided to set to driving of oncology. But in this patient, the chemotherapy is fine because it's a low grade. I would like that you tell us what do you want. Thank you.
Thank you very much. So what we're going to do now, before we move on to our presentation from Brazil, is, before we move on to our presentation from Brazil, what we'll do is open the floor to all three of our panelist areas. This is very cool, geographically located. We've got Brazil, Dominican Republic, and Miami. You should all be able to speak to and see each other now. Thought maybe give you a moment to discuss this case. We can also take any questions from the audience regarding this case at this time. Submit them through the chat window, but to our presenters, the floor is yours.
Were there any lung lesions? Was there a CT scan of the chest?
Yes, because it's fine.
Okay.
So,
Do you have an idea for how fast the tumor was growing?
I know. It's
Really?
not fine.
Slow, like a low grade?
Yeah, it's low grade.
And in the pathology, there were no areas of dedifferentiation?
Yeah, no.
No
It's conventional.
Okay.
Low grade and conventional chondrosarcoma.
Yeah, so generally we would manage these with surgery and possibly radiation therapy only. I am in complete agreement with your idea that we don't generally use chemotherapy for conventional chondrosarcoma, especially a low-grade tumor.
Yeah.
The issue is that the size and the location of the tumor looks like it would probably be an internal hemipelvectomy Did the orthopedic surgeons discuss the extent of surgery that would be needed?
Hemipelvic.
Hemipelvectomy?
Yeah.
Yeah. I mean, the only other issue is that there may be some clinical trials around of a medicine that's a isocitrate dehydrogenase inhibitor, IDH. And if that mutation's present in the patient, it may be possible to see if there's a clinical trial available somewhere. Right now, I'm not aware of any clinical trials that are open for that inhibitor currently, but there may be some in the future.
Okay.
Is there anything anywhere open?
No, and no compassionate.
I don't know.
So it seems like we're left with surgery plus or minus radiation therapy.
Okay, thank you.
Okay, so at this time, it looks like we're going to move on to our presenter from Brazil. That is Dr. Franzoli.
Okay.
And just give me a moment to change the slides over.
Yeah, fly by the seat.
Okay, and
hello.
hey, Dr. Franzoli, you should have remote control now of the slides. You want to give that a quick test before we get started here? Go ahead and click the mouse.
Hi, everyone is hearing me? Everyone can hear me?
We can hear you and we can see you. Do you want to just test those slides, make sure they're working for you?
Okay, can you go, let's go forward.
Yep, you have control of the slides. There you go. Excellent.
Okay. Sorry. So my name is Maria Alice. I'm a resident from the oncology department of our hospital, and I'm going to present a case of sarcoma. This is a 46-year-old male patient. He was a former smoker and had no other comorbidities and no familiar history of cancer. He came to our office reporting abdominal pain, and that started about a month ago. And at the physical examination, he had a big mass at the abdominal wall that was located at the right flank and measured approximately 8 centimeters and was very hard and firmly adhered to deep tissues. This patient underwent a percutaneous biopsy, and the pathologic result was an undifferentiated pleomorphic malignant neoplasm with necrosis and numerous mitosis. This was the immunohistochemistry panel, and that marked positive for vimentin and alpha SMA. The final pathologic report was an undifferentiated high-grade pleomorphic sarcoma, or also called a malignant fibrohistiocytoma. Here you can see the pathologic report. And CT scans were performed, and what happened is that we couldn't find any site of metastatic disease. So here you can see the huge mass at the abdominal wall, and he also had a site of focal abnormality at the liver, but that didn't confirm it as a metastasis, just in a specific lesion. The primary treatment we started the treatment with local radiotherapy for pain control, and the patient had 25 sessions planned, but after the 18th session, he presented progression of disease and hematological toxicity. So he underwent a surgical tumor excision, and the final pathologic report was the same as before, with revealing a malignant fibrohistiocytoma, giant cells type, and 3 margins. After that, we discussed it and we opted to not offer him adjuvant chemotherapy, and he underwent follow-up. Here you can see the final result after surgical excision of the tumor. And what happened was that 3 months after the resection, the patient presented progressive disease, and he presented 4 new hepatic lesions and also a bone metastasis. At this moment, we decided to start palliative chemotherapy, and we started doxorubicin. And what happened next was disease progression with a new bone lesion and a breast implant. We rediscussed the case, and we opted to start a second-line treatment with ifosfamide. And the best response that the patient had after 3 cycles was again disease progression, and now he progressed with spinal cord compression. And by this time, neurosurgery was needed to relieve the compression. So he underwent surgery plus radiotherapy. Here's the site of spinal cord compression. After that, we performed new CT scans, and again, there was systemic progression of the disease with new liver, bone, and hepatoperitoneal and pleural implants, as well as pulmonary embolism. Here you can see the massive systemic progression of the disease. At this point, we discussed the case again and with the patient, and despite this systemic progression with high burden of disease, he was still in a good performance status, and we started third-line treatment with docetaxel, and that resulted with a clinical response. So he had an improvement of the bone pain and reduction of the opioid dose and a better quality of life. We are still waiting the new CT scans to see the results of this third-line treatment. Thank you very much. So my question to you is, would you do anything different? How would you conduct this case? These were the medications we have available here in Brazil at the public health system. So I don't know, what would you do in Miami?
Okay, so good afternoon. I'm Bree Wilkie. I'm another one of the sarcoma oncologists, and I have to apologize for being late to the tumor board. But basically what you've seen is how aggressive these high-grade sarcomas can be. And so because of this rapid course, oftentimes if we're thinking that chemotherapy might be helpful, that's the rationale that we use to try it up front. Basically, you control the disease early on, hopefully, and you treat the entire body to try to avoid these micrometastatic foci of becoming apparent so quickly after surgery. It might have also made your surgery a little bit easier by reducing the size of the mass. And then finally, it kind of gives you some insight as to what chemo is likely to be effective for these tumors. At this point, it's that you've definitely pulled out the major active drugs. The one thing I might think about, if he's doing better and you have some room now to work with his performance status, I don't know if you guys have access to gemcitabine there, but the combination of gemcitabine and docetaxel usually is pretty well tolerated. And the data, at least from Dr. Mackey's group, did show that the combo was better than gemcitabine alone, although they didn't really compare it to docetaxel alone.
Yes. We thought about that, about the combination, but the patient was in a poor performance status, so we opted to just one line of chemotherapy, not the combination.
But at this point, do you think he's a little bit better, or would you? I mean, you can go either way.
Maybe we can discuss to add gemcitabine if he keeps going well.
Yeah. And then the other thing I might do is once you get to a maximum response in your problem areas, you know, especially the spine or anything in the liver that's causing problems, you might want to think about some focused radiation just to try to stall and control the symptoms where he was having the most pain. I think you already had done some radiation to the spine, but maybe looking whether any more is possible. I don't know, Dr. Trent, do you have other things?
No, I agree completely. If you can get some control of the disease, get some regression of tumors, that would be the time to consolidate in a palliative fashion any areas that are problematic. And then if gemcitabine doesn't work either, then you could also consider dacarbazine or temozolomide. And then if liver is the dominant site of disease, you can also use embolization. Sarcomas are generally fairly sensitive to hepatic arterial embolization, even bland embolization with foam particles.
Yeah, we don't think maybe the embolization would work because he has multiple sites of disease at the liver, but maybe if he presents a regression, we could think about that.
Yeah.
Thank you very much.
Thank you.
Okay, so there's some of the questions coming in from our live audience here, and we've got a question regarding this case from Marcio, who asks, what about the action of olaratumumab in this case?
We don't have this medication available in Brazil. I don't know if the board in Miami could talk a little bit about the medication.
Yeah, so as Dr. Trent was saying, the data supports that olaratumab seems to make doxorubicin work a little bit better, but at least, you know, obviously it's hard to get even for us, sometimes we have problems getting it in combination with drugs that are not doxorubicin. There is a big clinical trial going on right now looking actually at the combination of gemcitabine, taxotere, and olaratumab that we're very excited about. And we've been fortunate to have several patients be treated on that regimen, or at least potentially treated on that regimen. So over the next few months, we should have more data, and hopefully as the newness wears off, we'll be able to get that available to other places.
And there's another question that's come in from Adamar, who says, would you think the histology would be different? Because the response to the docetaxel and maybe just reading this as it's written, maybe add to gemcitabine. Would you consider pathologic review in this case?
We didn't consider a pathologic review at this case because he actually underwent two tissue samples, first the biopsy and then after the surgery excision. So I think we had good material and we could be able to do all the immunohistochemistry panel. So we didn't think about pathologic reevaluation.
Yeah, no, I agree. It does look like a pleomorphic sarcoma or what used to be called MFH. It does look like that on the histology. I'm not a pathologist, but it looked consistent with it. But the point that this pleomorphic sarcomas are generally not sensitive to docetaxel is a very valid point. In the phase 2 trials, it was completely active in sarcomas, but that's not to say that you might get an occasional patient who responds to it. So you could have gotten lucky.
We actually don't know if he is responding, but he's having just a clinical response that maybe the new CT scans show progressive disease again. So that's most probable.
And then the point that Dr. Wilkie made about adding in a little bit of gemcitabine if you can get away with it with this performance status is, it's reasonable if he can tolerate it.
Yeah, we'll think about that.
Okay, so we have some other questions from the audience, actually some great questions here. So this comes from Lillian, who asks, we have a 66-year-old woman, ECOG1, undifferentiated, unreachable peritoneal liposarcoma. What would be your choice nowadays, doxorubicin and olaratumumab?
Generally, we would, sounds like this is a dedifferentiated liposarcoma. And if that's the case, generally, even if it's a large surgery, we would approach with a surgical resection. If that's not possible, if the surgical resection is, the tumor's too extensive, involving aorta and SVC and other important organs, then we would give chemotherapy with the idea of potentially inducing a regression such that the tumor could be resected in the future. Our current frontline regimen is doxorubicin plus ifosfamide. That has the highest response rate. It's a higher regression rate than the phase 2 study, doxorubicin olera. If we had olera available, for instance, we do have a clinical trial that is doxorubicin plus ifosfamide plus olaratumab, and that would probably be the most aggressive regimen to induce a regression with a dedifferentiated liposarcoma.
I mean, remember,
Okay.
you want to. Sorry, I would just say you want to think about the goal of treatment for your patient too. For any sarcoma, you know, even if there's not an overall survival benefit, if this is a young patient that has a surgical option, if you can just get it shrunk a little bit, you know, that may be the more appropriate time to use some of these aggressive combinations, even without necessarily the overall survival data. So you want to customize for the particular patient in front of you.
Excellent. So there's one final question, and this comes from Gustavo, who says, I saw a paper testing aromatase inhibitor in chondrosarcoma cells with the idea that teenagers grow up after higher steroids levels. Does anybody have experience with such a drug in chondrosarcoma patients?
Personally, I've never treated a chondrosarcoma patient with aromatase inhibitor. We use them sometimes in desmoid tumor, sometimes in uterine leiomyosarcoma, particularly if it's lower grade, but I'm not aware of any data in chondrosarcoma.
Okay. Well, looks like it was a successful meeting here. And I think that's all we've got as far as questions. Just confirming that we're done. Yes, we're done. So thank you to all of our participants. Thank you to University of Miami and our participants in Dominican Republic and Brazil. We really appreciate you all coming together for this incredible multinational event. It's really amazing that the internet allows us to do this. And thank you on behalf of Oncology Information Group to all of our participants who came in. We had plenty of participants today. It was a very productive webinar. So we should be able to have a recording of this available in the future. And we thank you for your attendance and look forward to future programs.